I want to start by thanking very much all our speakers for giving us an excellent oversight of the available evidence that we have so far on this clearly extremely important topic of nicotine, tobacco use and the coronavirus. And also thank you very much to the organisers of this GFN conference for allowing us the opportunity for this live Q&A. We've had an overwhelming amount of questions. Everybody is extremely interested in this answer, and I'm going to do my very best as chair to try to organise those questions so that we can have a really good discussion about the core issues here. We've got around 30 minutes of Q&A. We'll aim to end at approximately 4:15 Central European time and then give you some time for a virtual coffee break. I am going to focus on the questions that all our panel members can have some input to. So any questions for specific panel members, I would encourage you to reach out to those specific individuals following this session. So just before we start, a couple of my very brief reflections. Some core themes across all the talks that we've heard to, really. First of all, the focus on the proliferation of evidence in the last few months and the developments that we've seen in new scientific methods. As Ricardo highlighted, we've seen an amazing proliferation in the publishing around coronavirus. Not surprisingly, but this really leads us to caution the quality of the evidence that's been published so quickly. Ricardo presented some contradictory evidence on smoking and coronavirus outcomes, requiring clearly further scrutiny. And thank you to Konstantinos particularly for the amazingly hard work that he's been putting in terms of updating the literature and the living review on the available evidence, which has been incredibly helpful to all of us in the field. A core theme emerging is on how we might make best use of the data we have to advance our understanding. Pinny talked about using big data. Ricardo talked about learning from other studies on viral outbreaks and what we can learn from history. Konstantinos talked about reviewing the international data we have on smoking and coronavirus outcomes. And Roberto, of course, focusing more on the use of nicotine in alternative forms and the potential harm or not of environmental exposures from vaping. So we need to focus on what we can learn from what we know already and what are the key gaps in research evidence. And then a final key theme, I think, highlighted very well by Marawa yesterday was the need for us all to really carefully, critically evaluate the data and the methods used in reporting that data. So with that, I'll move to our first question. This is a question asked by Clive, which has clearly been very popular and upvoted. And he asks, what is the potential possible protective role of nicotine? Is it being taken seriously, this protective hypothesis, aside from the wider scientific community? And what has the wider reaction been? So I wonder if we'll start with your thoughts on this, Pinny, from a kind of data analytic perspective.
Well, we're seeing many people, mainly in social networks, talking about the fact that they believe that their smokers or vapors might help them because newspapers and main blogs, they only catch headlines such as nicotine saves you and smokers go less to hospitals. But as Ricardo said, some of these papers might not be that great in regards to methodologies, and people tend to go to headlines. And I think we should wait because there's not enough data, just as anyone here said. The problem here is that people see what they want and decide just what they think they should believe in. And I think it's too risky right now because we don't have any evidence that nicotine saves or nicotine takes people to the hospital at the moment, in our systems at least. And I think the presentations here showed pretty much the same, that we still don't know enough.
If I can follow on Pini, if I may. You know, smokers and probably even vapers there is some ambivalency in their behavior. So if you provide from the media an excuse to keep smoking or keep vaping, they will do so.
Okay, I think, and let me also intervene. I think that what the Clive is asking is whether scientists outside the tobacco control arena consider the potential that nicotine can have protective effects as a serious hypothesis, or a hypothesis that is worth further investigating. And I think that his question implies the predisposition, that exists within the tobacco control community concerning using nicotine for anything, let alone as a therapeutic option. And my response is that, yes, we have been contacted by several scientists who have never worked in the tobacco control field. They are not at all involved in this field, so they don't have this interaction with the bad industry and the bad nicotine and the bad products, let alone that we never discussed about the use of alternative products in any of our publications. We're talking about nicotine and the use of nicotine through pharmaceutical products if we find an effect. But yes, there has been considerable interest and many publications of opinions based on our hypothesis, which from scientists, as I said, who are not in the public health field. They are not working in tobacco control, and they express a lot of interest, and they definitely think that this is something that should be further explored. So my response is yes, there is a lot of interest outside the tobacco control arena.
And I think this interest is also emphasized by the most recent data on smoking status and population-based studies. These studies have been sponsored by the Ministry of Health and the health authorities of Israel and France and the UK. And the lead authors have nothing to do with tobacco control. So I think this is guarantee of the independency of the data that is being produced.
Mm-hmm. Yes. So I'm just going to move to a linked question and ask you to respond, Roberto. So taking the question slightly out of order, Dom Garrett asks, what are the most significant challenges or hurdles in getting the general public to accept data that might be contrary to their currently held beliefs about nicotine and smoking as being primarily negative? Roberto, what are your thoughts on that?
Well, I agree with what Ricardo Constantino Pini said before, but I would like to add that there is also rejection. For example, we recently submitted for publication a study on Mexico that Constantinos described, and Jose Manuel Mier, who is a physician, is one of the co-authors, was trying to discuss this in the hospital where he works, and he was rejected. He was accused of favoring tobacco industry, and also I was invited for a press conference just to talk about this issue. Nothing about vaping or smoking or anything, just nicotine. And again, the press conference was hostile. Questions of issues of interest came about, very stupid questions that had nothing to do with the topic. So there is a rejection, and how can we address that? We have to insist that these are facts. Yes, okay. Yes. We have to insist. People have the right to know.
I really agree. This is complete nonsense. I'm sorry for using this word nonsense, but this is what the data says. The study that Roberto is talking about is a study which is evaluating risk factors in general, everything, for hospitalization and for diagnosis, for hospitalization, for adverse outcome, using data that were released by the Mexican Ministry of Health, not by ourselves. The data included one variable. The data set included one variable with reporting smoking status as smokers or non-smokers. There was no data on former smokers. We don't even know where former smokers belong in this data set. And what we found was that smokers were 23% less likely to be diagnosed with COVID compared to non-smokers. This is a fact. Whether you like it or not, it is a fact. It has nothing to do with any methodology because it's not our methodology, it's not our data set, it's the data set released by the Mexican Ministry of Health. There is nothing to discuss other than the fact that this is evidence provided by the Mexican Ministry of Health. So there is no debate about that. Whether you like it or not, you will either accept it or you are a troll. It's that simple. We can discuss, and of course we can debate endlessly about why this is happening and what are the limitations. We do mention limitations in all our studies, and there are definitely limitations everywhere. But when you deny a fact, because this is exactly what the data is showing, it was a simple logistic regression analysis in which we added all the variables as independent variables. We didn't remove anything. We didn't change anything in the coding of the variables. We didn't, manipulate the data in any way so that we can produce a favorable effect for smoking, even if we wanted to, which of course we didn't want to. But this is a fact, and there is no debate for facts. There can be a debate about interpretation, why this is happening, what does it mean, what else can we do or should we do about that? But there is no debate about a finding. This is a finding, full stop.
Mm-hmm. Thank you. So I will perhaps come on to the discussion about confounding factors in these studies shortly. But I think what you're talking about here, Konstantinos, really links to a question asked by Andrew Thompson about the importance of open science. So what's the place we have now for open science featuring open, visible peer review in helping us to improve interpretation and clear reporting of these study findings? Pinny, would you like to start with perhaps responding to the importance of open science?
Well, I think that there's kind of a problem in regards to nicotine and open peer-reviewed science, because I think that some of these researchers are backed by or funded by industry-related companies, and not all journals will accept papers that were written by someone that's even remotely connected to the tobacco industry. And I think there might be a problem here, because as long as you say and indicate straightforwardly that you're backed up by this and that sorts of funds, someone needs to check the data and give you a good peer review. And the fact that some papers and some analyses are not being even able to get published because of who funded them might be a problem, because not many researchers would like to publish pro-vaping, pro-smoking, pro-nicotine papers, and the only ones who can't do that.
So if
we're talking about COVID-19, there is not a single paper funded by any commercial entity right now concerning COVID and nicotine or smoking. Not a single one. So if we're talking in general about research, yeah, there are issues. But concerning COVID, there is not a single publication which discusses about effects of smoking or whether smoking is a risk factor or a protective factor. Neither in hypothesis nor in analysis of data, of observations, clinical observations, for example. None of them has been funded by any commercial entity linked to nicotine, not even by pharma industry. So there is no such conflicts or potential conflicts. And still, even if we may see in the future, I don't know what's going to happen, you have to look at the data. And you have to look at how the data were used, what was the method of analysis, what was the method of collecting the data if the data were collected by the authors themselves and it's not, a meta-analysis, for example, of other studies. Other than that, there's nothing else you should do. I understand that you implied that they will not be published or it's going to be very hard to be accepted. I agree with that, but that doesn't mean that this should be the norm or that this is something normal and acceptable. But you have to judge the content, take into consideration the conflict, which, as I said, for now it doesn't exist, but maybe in the future we will have some studies like that. Of course, take it into consideration. Of course, look at the data more carefully. But, you know, with Sergisphere and the scandals with hydroxychloroquine and the AC inhibitors, the two papers that were recently retracted, there was no obvious conflict anywhere. They were published by the biggest medical journals, and they were a complete disgrace for medical science, which should have been taken care of in the peer review process, because the data they were presented were pretty odd, to say the least. So you see that conflicts should be, of course, transparently mentioned, and funding should be transparently mentioned, but that's not in order to reject a paper because of the conflicts. You have to look at the data as carefully as possible and at the methodology as carefully as possible, and provide criticisms, but relevant to the data and the publications. I mean, we don't want to follow, and we should never follow, Bloomberg strategies. I'm going to mention them by name. So, and I'll be very clear, Bloomberg or Bloomberg-funded strategies of not discussing at all about the data and about the findings, and only discussing about real or imaginary conflicts. Because this is what is happening with most, if not all, of Bloomberg-funded organizations, which grow up in an unprecedented speed all over the world, and have the only task they have is do ad hominem attacks, not only in those who have real conflicts, but also in those who don't have any conflicts, and present them as having conflicts.
Ricardo, would you like to add a comment on the future and the importance of open science publishing in this field?
I really believe that open science and having the possibility to publish raw data in open research repositories is going to be the future. It's going to be the only way people can scrutinize the quality of the data and reutilize that if there is some methodological issues. On top of that, I think if this endeavor is exponentially emphasized at the international level, this is going to provide an additional barrier to to data that can be manipulated. Just to give you an example, if you provide an open repository for science involving 7 different institutions all around the world, I mean, there'd be no chance that the data will be manipulated at all. So I'm strongly in favor that open science and open research repositories will be available to scientists all over the world. And let me tell you something more specifically about the story about COVID and the background of the scientists presenting the data. At the beginning of the COVID-19 pandemic, there were only 2 little systematic reviews. One published by an Italian group. Actually, the guy, Professor Giuseppe Lippi, is a professor of biochemistry. And the other one presented by Greek group led by a very well-known anti-tobacco activist. He's very active in the European Respiratory Journal and many of the committees, anti-tobacco committees in the journal. The 2 systematic reviews got to a completely different opposite findings, conclusions, and that's amazing. To me, this is an indication of the unscientific approach of many scientists to the data. And there's also another point that, the COVID-19 stories is a methodological problem, not just for smoking. It's a methodological problem across many other speciality. There has been already 15 retractions, more than 200 corrections, and another 200 erratums in a very short period of time. This is palpable. I'm an associate editor of a COVID-19 special collection, and I'm telling you, it's very difficult to find now experts on COVID-19 that can dedicate their time to an adequate peer review. What happens? They will delegate younger people who have absolutely no experience in that particular area, and the results will be acceptance or fast acceptance of paper of poor quality.
Yeah, so lots of lessons to be learned for the future of the traditional peer review system. I'm going to move us on now, if I may, because we have a lot of questions to get through, and I want to move to some questions specifically on coronavirus outcomes and use of nicotine in alternative delivery forms. So Roberto, I'll come to you next. Dom Garrett asks, is there any data on the nicotine delivery method, i.e. smoking versus vaping versus snus, and how that may affect the risk factors for COVID-19 hospitalization or morbidity and mortality outcomes?
No, there is no data. There is, well, Pini might have a good result later because he's really mining the data. I don't. What I do is I just look at the COVID papers I from different sources, but so far, and I've challenged people in talks and also in social media, say, just give me one name of a vapor in any hospital, China, Greece, whatever you want, that has a vaping antecedents. It's that is a vapor. There is a vapor. Just give me one. There isn't. Now they say, well,
come on, don't exaggerate. We had two in Athens. 2 of the 255 patients who were hospitalized with COVID-19 were reported to be vapors, and we also had 2 heated tobacco product users. We also had 11% of the hospitalized patients were smokers, while the smoking rate in Greece is about 30%. Even the smoking rate in people above the age of 65 is 25%. So by far less than what you would expect based on the population sample. But of course, there are vapors. I also personally know vapors who were diagnosed with COVID. So it can't be zero. But you will rarely find vapors because they are also a rarity by themselves. You mentioned that in Mexico it's less than 1%. It's not very frequent. It's not very prevalent vaping and use of other alternative products. An exception would be Sweden, and in Sweden, snus use needs to be examined seriously because there's a big part of the population, especially males, using snus.
Mm-hmm. Yeah, but
Pini, do you have any chance to scrutinize the data in Sweden for snus usage and COVID-19 outcomes?
Not yet. We're just starting to look at specifically COVID, and we're doing something similar to what we did for EVALI. So I'll have to chime in a month or two, or let's say GFN 2021, but no, we're not there yet.
no,
And do you have any insights, Pini, from your mining of the data around alternative uses of nicotine and COVID outcomes?
I'm really sure Roberto wants to say something, so I think we should move to him, and then I'll come back. It's okay.
There is something important. Yeah, I agree with what Constantino said. It was just that there is not a big flow, right? But there is another factor that I did not include in my talk, but that I would like to emphasize now, and it's the age. It's like Bill Clinton would say, it's the age, stupid. Like, if you look at the distribution of ages in vapors, it peaks at least in Mexico. It's between like 24 years old, the typical vapor, and probably in the US is closer to 30, In the UK, it's about 34. These are the peaks. Most vapers are below 40 years old, right? And most serious COVID patients are over 40, 45 years old. So in a sense, the age distribution of vapers is somehow protective. Perhaps not related to vaping per se, but
more than protective makes it very difficult to analyze.
Let me clarify something. I think it's important to understand something. It's a different discussion about susceptibility to get infected and have COVID-19, and a very different debate discussing about serious disease, which may end up in hospitalization or in an adverse outcome. Concerning susceptibility to be infected, there is no specific age predisposition. Everyone is equally susceptible to be infected, all age groups. So when you look at COVID diagnosis, then there is no age predisposition in COVID diagnosis. There may be an indirect age predisposition because probably more severe cases will ask to perform a diagnostic test and will be diagnosed. But if you look at population data, and we assume that everyone will have access at some point at least to the diagnostic test. So everyone with respiratory infection symptoms will be tested for COVID, for SARS-CoV-2. In that case, there is no age predisposition. Everyone will be equally susceptible to be infected. Of course, the severity of the disease is going to be different. So studies like that evaluate diagnosis, like the Israeli study, in that case, the age groups don't affect the analysis. And also, I'd like to clarify, because there is also another question which is relevant to this discussion about age and whether in our analysis, because of the older age of people who get hospitalized for COVID, this may create some sort of a discrepancy when you compare the smoking prevalence in hospitalized patients with the smoking prevalence in the population. In the latest meta-analysis, which was a meta-analysis of 18 published studies and 12 preprints, that is in press right now, we co-authored that with Ricardo and some other colleagues. We made, besides the gender adjustment in the expected prevalence, we also prepared an age adjustment. And the age adjustment we did was, instead of considering the smoking prevalence in the whole population, we only considered the smoking prevalence in the age groups 65 and older in the populations, which was the worst case scenario because, first of all, the average age of all hospitalized patients was by far lower than 65. In many cases, it was lower than 55. And we know that the smoking rates are the lowest in the age group 65 in the general population. So in reality, in this analysis that is going to be published very soon, we underestimated the expected prevalence because we only used the 65 plus age group smoking rates, and still the smokers were underrepresented by, they were about 1/3 the expected prevalence. So the smoking prevalence in hospitalized COVID-19 patients was still 1/3 the expected prevalence. So,
okay. So yeah. I just want to stay fixed on this question about use of nicotine in alternative forms. Penny, do you have any data or insights from that?
Yeah. Not from patches and Snus, because most of the people that go online, forums, web pages, Facebooks like that, they normally don't talk about it. But within the vaping community, I can tell you that we've seen many people that contracted COVID-19. Most of them reported on minor symptoms or reported on only a flu-like, but again, we have the age factor here. But there are also enough vapers that we're talking about hospitalizations experiences. They were hospitalized and Of course, if they tweet it afterwards, they get out of it. But again, the majority of vapers that contracted COVID, at least through our systems, reported milder symptoms. Again, these are 20, 30, 40 years old, so we need to adjust everything.
This is a limitation of the approach of your platform, because you're focusing on, vaping blogs. And I mean, if I was a vapor and I had symptoms, I'm going to talk about it. But if I don't have anything, I'm not going to talk about it. So if there's somebody having, COVID-related something, I would be blogging, I would be talking about it, and there will be spike in your platform. So basically, you really need to have a sort of how in order to have a more balanced assessment of the situation.
There is already a first study, the one I reported, conducted by physicians in Barcelona. That was an internet survey for 3,517 participants and worldwide. And the report was that, and people in lockdown, and about, of all vapors, about 3% had symptoms that could be diagnosed as COVID, and 4% smokers, and 10% among non-nicotine users. Of course, it's a very limited study, but we need to do more studies of this type, and rely on more databases and so on. And but so far, there is no. This is the point I was going to make. If vaping, and I'm trying to contrast with what the NIDA, for example, Dr. Volkov, or Glantz, or the Major de Blasio, saying that vaping is terrible, is a huge factor. And the data, whether what is Pini or Constantino's reporting, it's not showing that. It's not showing that vaping is really a major risk factor. I think there are sufficient inferences, solid inferences, to be able to conclude that.
Okay, so linked to that point, Roberto, Harry Green has asked, he draws on an important point about the reporting and the messages being given out by the World Health Organization. Now, they have specifically said that potentially the hand-to-mouth action of using vaporizers might increase virus susceptibility, but the data we've presented and discussed here seems to really refute that. So do we have any data looking specifically at that, the behavioral transmission of viral infections by smoking or vaping?
I don't know of any. This idea, like, well, if viruses can be transmitted this way, they can also be transmitted by sharing bottles or glasses or whatever. So to what degree this is so significant that the major international organization should ring the alarms about that? I think the WHO is really missing the point if they make such a big issue of that. I don't think it's a very big issue. Of course, viruses can be transmitted in many ways. If they can be transmitted, if there is evidence that this virus can be transmitted by touching surfaces, well, then of course can be transmitted by sharing devices of this type. Yeah, that's true. But I would tell Tedros, and so what?
Mm-hmm.
Really,
perhaps it's more a question of the political messaging. I don't know if you might want to comment on that, Konstantinos.
There is basically no data to suggest that smoking or other behaviors like that, use of other products which involve inhaling and exhaling, increase the transmission potential. It is a possibility, of course. I don't think that people who smoke exhale on the face of others. We don't understand basic things about the coronavirus yet, like, for example, what is the viral load that is needed to produce an infection to someone else. We know from all other infections that you will never catch a disease by if you receive one virion or one bacterium. It's impossible. There is a specific dose, a specific viral load that you need to receive in order to get the disease. We have no idea how much that is. So we have no idea what kind of behaviors and at what extent can they transmit the disease. I think there is a global hysteria, and that's irrelevant to smoking and nicotine now. There is a global hysteria concerning the ways that the disease is transmitted. We have a lot of evidence that transmission is happening certainly in closed spaces and in very close contact, for example, with family members and with other relatives. We have limited data on the extent of the speed and the extent of transmission in open spaces. We will have, I think, a lot of data when we see the effect of the recent anti-racist protests in the US and in Europe, which were done under extreme overcrowding with masks, but I think with that level of overcrowding that I saw in the pictures, in the photos around the globe, masks will have a minimal effect. But it happened on the outside, so in the outside environment. We will see how this will affect a new wave, a possible new wave of confirmed cases, because if the transmission is as easy as the WHO implies, then we should see a huge spike of new cases in the next 2 weeks, so not now, coming from these protests, which were done completely uncontrolled, and interestingly enough, in places where very strong lockdown measures had been implemented with devastating economic consequences. The same authorities which had implemented these rules, they also allowed the protests to be held without any protective measures, without anything, basically no control, and they even supported that, which is another political irony of a different level. It's not about tobacco control, but it's a political irony.
Yeah, here regarding the aerial transmission, there is now evidence, and I've been collecting this evidence carefully, that it's the transmission through air is through saliva or secretion droplets that are big. It's because there was fear, very reasonable fear, that this transmission could be also by very small droplets or even droplets nuclei, and this nuclei, these droplets nuclei or very small droplets, they can be buoyant, they can be in the air for a long time and travel long distances. There are cases, for example, with the previous SARS and also with influenza, in which viruses were transmitted even through ventilation systems, very far away. But this is not the case. There is now mounting evidence that this is not the case with the SARS-2 virus. The aerial transmission is... I'm
very aware that we're going to be cut off and run out of time soon, so I want to
but I need to clarify that. It's another, it's another hysteria. When a virus is released into the atmosphere, it gets diluted at such huge volumes that it's basically impossible for anyone, even if they come in contact with one droplet, they will not develop a disease. We don't know the virus load needed to transmit the disease, and I don't believe that it is possible. If someone exhales anything, and this travels around in the environment, even if it stays, on the surface and doesn't go to the pavement or to the road or anywhere else, it's going to be the viral load is going to be so low and so much diluted to the surrounding air that it's going to be impossible for anyone to be transmitted. You need very close contact in order to get the disease.
Penny, a final comment from you.
Yeah, I completely agree with what they said, but people are afraid, and we see in the data that non-smokers are getting away from aerosols of vapors because they don't really know the exact fact, but that's what they believe in. So the data and science is one thing, but how people actually act is completely different.
That's a good thing, but that also doesn't explain why they get more infected than smokers themselves.
So in our final point now, I just want to pick up on the final question we had, which was around an important study happening in Sweden around the potential use of snus for coronavirus outcomes. I just want to ask each of you finally to please tell us what you think are the key research questions that still remain unanswered in the field of nicotine and coronavirus outcomes. One question.
I don't think that anything is answered yet. We are looking at it. There is strong suspicion, I can say, that something is happening. There are no definite conclusions yet, and that's why we cannot recommend use of nicotine for COVID-19. We will eventually need a clinical trial, but we have a lot of indications that something is happening, and it's growing. I mean, the data are growing, suggesting the same thing. So I think we definitely need to look at it.
Thank you, Roberto.
Well, that's. I think we've said it all. As Peter said, very important. It's the science says something, but perceptions. But we have to insist that people are well informed. That's it. That's my conclusion. We have to be persistent on that.
Penny?
I completely echo Roberto. We need to understand what people think and convey the true messages to them according to their thoughts and not to what we believe and think that they need to hear.
Thank you. And Ricardo, the final word.
The final word. As an immunologist, let me remind you that viral load is not everything. We have a fantastic defensive systems, and that explains why young people and children are better defended than elderly, because immunosenescence is playing a part. In terms of the future, I would really ask Caitlin in the UK to try and dissect out the impact of COVID-19 amongst the vapors, because in the UK there's such a high prevalence of vapors that would make a fantastic naturalistic study. So over to you, UK people.
Absolutely, thank you. And of course, one of the big issues that we have is the difficulties around the collection of data on use of nicotine aside from smoking, which is clearly a key barrier that we need to address in studies going forwards. So I want to round up now. Thank you all very much. Thank you to our audience for joining this fascinating session. We could go on all afternoon, but I need to let everyone go now for their virtual coffee break. We'll be back in approximately 10 to 15 minutes at 2:30 Central European time for the next session focused on tobacco harm reduction, taking stock on regulation. Thank you to all our speakers.